Welcome to Black Hat Windows 2K Security, held February 14th through the 15th, 2001 in Las Vegas, Nevada. The following videotape was recorded live at the conference and produced by the Sound of Knowledge Incorporated. This is recording number 19, Technical Track, Healthcare and New Federal Security Protections.
And then Congress, as they sometimes do, tacked on something they called administrative simplification, which usually gets a round of laughter. When's the government ever simplified things for us? That has far overshadowed that original intent of the insurance portability aspect. Well, what's administrative simplification about? The idea is Congress felt there's a way to save some money in here, and I'm one of those that firmly believes that it's true. Standardizing the electronic transactions. What Congress recognized is that in the healthcare industry, there are only a handful of standard transactions that flow between the healthcare partners throughout the healthcare delivery system. And a lot of us are already putting those transactions in electronic form. Used to submit claims on MagTape 10, 15, 20 years ago. It's not new. So if you sign up, you're a new employee and you get an opportunity to enroll in a new health plan, there's an enrollment transaction. You go to the doctor, a claim is submitted to the insurance company, there's a payment or remittance advice, you go see another specialist, let's say, and so there's a referral transaction. And along the way, somebody checks to see if you're actually eligible for the services that you're getting, whether it's lab work or a doctor's visit or an inpatient stay, whatever. So there are a handful of these transactions, and they're sort of standardized today, but not really. At one point in my career in information systems, I was responsible for the hospital billing systems applications at Mass General Hospital in Boston. And I had to have a staff of about 3 programmers doing nothing but tweaking the claims systems because the payers would want changes. Yeah, it's a standard format, but out in this free format field at the end, Medicare wanted this, and Blue Cross wanted that, and the commercial insurers wanted something else. So we'd have to be tweaking the software constantly and tweaking the front-end registration systems to continually gather more and more data to be able to provide that information back to the payers. So that's just one example where I completely agree that a real standardization of those formats will reduce a lot of the administrative overhead, software maintenance, and so on. So they said we're going to have standard record formats for each of these transactions, a standard set of codes if we're all using a certain nomenclature or set of codes to report a diagnosis. That's going to be the official standard, no deviation. Procedures, all kinds of services. We are using a lot of code sets today that are fairly standard, but again, locally, we've tweaked them and modified them, and now the rule says, standard across the country. Standard identifiers. Going to have a single, unique, universal identifier for every employer, every insurance company or payer, and every provider. And originally in HIPAA it said, every one of us. The Institute of Medicine has been for a while writing about pushing the concept of an electronic medical record and kind of universal, unified systems. And one of their thoughts was the cradle-to-grave medical record. You get assigned a medical record at birth, maybe it's a variation on Social Security number, and that links all of your health information together across your lifetime. Now, while that's very appealing for some purposes, maybe for your health care, or maybe not, certainly for research it's appealing. But there are clearly real issues in terms of our own individual privacy and ability to control who uses our information, what they do with it. Some purposes may be legitimate, but as long as the more we standardize, and it's standardized in electronic form, the easier it is for people to inappropriately link information about us. Well, the compliance date for the transactions, by the way, the different components of HIPAA, by the way, have been broken down into different rules that each have their own deadline in terms of compliance. So the standard transactions here in code sets, they've been finalized, and the compliance deadline is October of 2002. Well, as I said, this standardization raises all sorts of questions and issues in terms of security and privacy, which Congress recognized. And so they said, in addition to these standardized, am I back again? Yeah. We're going to turn to the Department of Health and Human Services and ask them to come up with some security regulations for us. And we're going to pass a health privacy law, medical information privacy law. Congress gave themselves 3 years to pass a law. They missed their deadline. There were many bills presented. They were very contentious, never got out of committee, split very much on partisan lines, about a half dozen issues, split right down on party lines. So that was stalemated. Fortunately, they had the foresight to write into this law in fine print down at the bottom, in case we miss our own deadline for a health privacy law, we will once again turn to the Department of Health and Human Services for some regulation until we can get our act together and actually pass a federal law. That was supposed to be a stimulus, kind of a burr under the saddle to Congress to get their act together and pass something. Didn't work. So as you probably all are well aware, one of the basic or standard definitions of information security is the assurance of these three things: confidentiality of the information, the integrity of the information, and the availability of it. The healthcare community was very focused on the confidentiality aspect. I want to protect this data so that only those people who are authorized and have a business need to know can get to it, and everybody and every other process is somehow kept out, whether it's a paper record or electronic. But the availability and integrity issues, they were kind of puzzled about. If you read through the proposed security rule, it talks about things like disaster recovery and virus protection. A lot of people read that and thought, what the heck? What's going on here? Well, those are standard ways to assure availability of information primarily, but also integrity. Well, privacy, on the other hand, is a word that you tend to hear more from lawyers. Anybody in here a lawyer? No lawyers in the audience? Oh, shucks. Well, unfortunately, I think the lawyers are going to have a heyday with this. Some lawyers themselves would say that HIPAA is the Full Employment Act for lawyers. A lot of the lawyers apparently wrote the privacy rule, which means technologically it's a little screwed up. But anyway, I won't dump on lawyers. But privacy is usually something that lawyers talk about. We talk about it in terms of the individual's right to privacy, which, by the way, we don't have in this country. We've got little carve-outs where we have some privacy, but there's no universal privacy law, as there is with just about every other modern nation on the face of the earth. U.S. sort of fallen behind on that one. That's where our culture of entrepreneurial independence and capitalism, and if you can find a way to make a buck using data, go for it. Kind of clashes with that idea of privacy that the EU seems to value more than we do at this point, but we're coming around. At any rate, these two concepts, security and privacy, very much go hand in hand. I've actually heard people stand up and talk about HIPAA and say, security and privacy, two separate things, they don't have anything to do with each other. Wrong! Heaven help us. You cannot have privacy without security, for one thing. And in fact, the privacy rule comes right out and says that, sets the record straight on that. But essentially, it's just the other side of the same coin. They fit together. We as organizations have security programs to help protect and assure your privacy. And in fact, the privacy rule that we have today came out of the fair information practices developed in the early 70s that led to things like the Fair Credit Reporting Act, for example. How many of you have taken advantage of that and actually gotten a credit report? Are all of you aware of that significant piece of legislation that entitles you to?
Some of them may not have been born when it passed.
You're right. There could be a few people who weren't even born. Well, you know, back in the olden days, when we walked to school barefoot through, 20 miles through 6 feet of snow, there were some, there were some pretty awful credit problems, horror stories. You had a great record, you went to get a loan, a mortgage on a house, and you kept getting turned down, and you couldn't figure out why, and you'd ask and nobody would tell you. Lots of horror stories. Well, under this law, basically it says you're allowed to get a copy of your credit report, your credit record, and it has to be written in plain language. And you have a right to challenge and correct errors. So on. Well, these principles, all part of the fair information practices, and in fact adopted by the EU countries, and it's kind of spread far and wide. We kind of dropped the ball a bit in the 70s here, though. Well, when Congress wrote HIPAA, and they were expecting to pass a health privacy law themselves, they wrote in there that HHS, the Secretary of HHS, should give them some recommendations. After all, the Department of Health and Human Services has all sorts of components to it in the healthcare industry, advisory groups like the National Committee on Vital and Health Statistics, NCVHS, which basically goes out and finds out what's going on and makes recommendations. And they made quite a few recommendations to Secretary Shalala. Well, Secretary Shalala came out with this report that stressed these principles. Security. Anything you write into a privacy law has to have security in it as well. You have to protect the information. And in fact, this is one area where the regulations, the HHS regulatory powers are very restricted. They are only allowed to regulate healthcare providers, healthcare plans, and healthcare clearinghouses. And so until there's a law, it cannot extend to other business entities that have our health information. At any rate, I'll come back to that. Boundaries. If I divulge my innermost health secrets to you, my doctor, so that you're going to make me well or keep me healthy, I expect that you're not going to turn around and use that information for a significantly different purpose without first coming back and asking my permission. Any of you involved in developing privacy policies or practices for something like a website, internet site? It's all these same principles, right? Fair information practices. So you can't use the information for something significantly different, a different purpose, without coming back to me and getting my permission. Consumer control. I ought to have a right to see what you have on record about me. What if there is an error? I ought to be able to see that and get it corrected. Get a copy of it. And I ought to be able to know who else has this information. Whom have you shared this information with? It's another point in the Fair Credit Reporting Act. Accountability. You break the rules, we break your legs, as they say in Boston's North End. And finally, public responsibility. That's really, I think, the toughest one to deal with, to come to terms with, because there's a lot of debate here, a lot of mixed feelings. It's finding the right balance for the country between an individual's right to privacy. How much do I as an individual get to control how my information is used versus the public good? And this might be public good in terms of research, in terms of law enforcement. Lots of government agencies have lots of rights to our personal information for lots of reasons. So where's the balance point? That's a tough one. And in fact, Ms. Shalala changed her mind on that one a little bit between this report and the final policy or final rule. Who who's covered by this? Well, as I mentioned earlier, the security and privacy rules coming out of Health and Human Services are constrained. They only apply directly to the healthcare industry. Healthcare providers, which is actually a very broad list. If you read through it, it includes pharmacies, dentists, all kinds of entities, as long as they engage in electronic transactions of the type I mentioned earlier, either directly or through, say, a billing agency. Healthcare plans, that includes all the health insurance companies out there, as well as government agencies, federal and state agencies, Medicare, Medicaid, lots of others, and clearinghouses. Those businesses that are transmitting the data, reformatting it, mushing it around, but essentially the middle folks in there. And then because HHS is constrained, all those other entities, a billing agency, a coding agency, legal counsel, auditors, these are all business associates, and they may have access to this information, but they're not directly covered by these rules at this point, not until there is a law. So we who are directly covered have to develop very strongly worded contracts, business contracts with our business associates here. There are lots of organizations out there that have health information about us that are beyond the scope of HIPAA today. Life insurance companies. Any of you gotten life insurance recently? Last time I got more life insurance, a nurse came to my house. She took all my vital statistics. She took my blood pressure. I think she probably took some blood. Well, if that's not health data, I don't know what is. But it's outside the scope of this because it is not in the context of providing health care to me. And so HHS could not regulate the life insurance industry under this. Workers' comp and disability, similarly, are outside the scope. Research. I could set up a table on the sidewalk and put up a sign and say, $10, I'm doing research on diabetes. Fill out the form, give me a blood sample, and I'll pay you. Totally outside the protection of any law like this today. So travel at your own risk. What is covered? If you are one of those organizations that's covered by HIPAA, it's a fairly broad scope here. It's all individually identifiable health data. Now, in the privacy rule, it doesn't matter what form it's in. It's not just electronic. It's electronic, oral, paper, everything, anything. And it includes all information about me when I present to you as a patient or a member of a health plan. Even just my name and address and phone number. That might be, as the lawyers say, in the public realm. My information's in my local phone book. It's on the internet. It's still covered. Yeah, Jack.
Can you have a mixed group problem? Like you're saying somebody could stand on the street and take health claim or take blood. And I'm thinking about the blood bank. Blood bank gets donations of blood. So on the input side, they're not health care takers. But on the output side, they're providing blood to the health institution.
Real good question. There's an awful lot of confusion in the law and in the regulations, and that's partly why the lawyers are going to have a heyday. There are a lot of questions that are not answered, and no lawyer has an answer. We'll only see through court cases how the courts come down on some of the issues. But what has become very clear is that many organizations, many businesses serve in multiple roles. And in some of those roles, they are covered, and in others, they are not. And a blood bank is one where they've kind of changed their tune a little bit. Sometimes they are, and sometimes they aren't. You would think that the donors would be protected, but just as Jack pointed out, I think the final rule, privacy rule, says they're not, but the recipients are. It's one of those kind of, it gets really convoluted. But the list of providers is pretty broad. It includes not just your typical doctor or nurse. It includes all kinds of therapies and services, even indirect, certainly labs, prosthetics and orthotics, in vitro fertilization, all kinds of tissues. Anywhere where the first test is just, are you providing a health care service to someone? Then there's this concept of de-identified data. There was a woman at MIT a couple years back, LaTanya Sweeney. Any of you recognize that name? She took a set of publicly available data that's very common in this country for, at the state level, there to be a state regulation that says, let's say all the hospitals in the state must report on a monthly basis all of the patients they have admitted or discharged. And then the state, some public health agency collects all this data and theoretically de-identifies it and then sells it to a state hospital association or other kinds of organizations that take this data and analyze it and do all kinds of things with it, theoretically beneficial to the public good. But the idea has been that no individual's privacy is at risk because the data has been de-identified. Somehow it's been encrypted or stripped of identifiers so that this data set could never be used to re-identify any individual. Well, what LaTanya Sweeney did in Massachusetts was buy one of these data sets, which anybody can acquire, and then she put it together with other publicly available data, such as local census data. And she was able to re-identify every single patient in that data set. Now, one of her mentors at MIT, who's a friend of mine, said we weren't particularly surprised that she could do it. After all, those folks at MIT are so smart. He didn't say that, but sort of the sense. He said, no. It was just so easy for her to do it. Anybody could have done it with just a little bit of knowledge. Well, she wrote a hefty paper. Anybody who's interested in finding that reference, let me know or give me your business card. But relatively easily re-identified. So the fact is, that's a common practice across the country. And our data, if you've been admitted, you can bet that your data is floating around out there. And if somebody wanted to go to the trouble of re-identifying, it wouldn't be too difficult. The security rule, which is still only in proposed form, it has not yet been finalized. Nobody's sure when it's going to be. I lost every bet on that one. I thought for sure Clinton would pass that before he left office. And I understand that he just marshaled all the forces on the privacy rule, which was far more controversial, and just didn't have any resources left over to get the security rule out. So we'll see under Bush what happens, or under Tommy Thompson. But the security rule focuses strictly on the electronic data. Now, everyone expects, as with federal rules, that each year the government reserves the right to change these, and it is expected that with each passing year, these will become tightened up, especially on the security side. The first pass, just dealing with electronic, and some of the fuzzy areas in the proposed rule will probably be resolved in favor of a more lenient or a looser interpretation. But we can bet that it will be ratcheted up or down, whichever you ratchet, tighter over time. The privacy rule, as I mentioned, was finalized. That was finalized in December of this past year. And the deal is, there's a law that says Congress has 60 days to think about this and call it off. I don't think the rule, that law has ever been invoked, but it's there. So there's the date of publication in the Federal Register, and then 60 days passes, and then it's the effective date. So we're almost up to the effective date. And then 24 months to become compliant for all but the smallest health plans, which will have a third year. So they'll have till 2004. Security rule, I give up. I don't know. Obviously, built into the privacy rule are security requirements. So as far as I'm concerned, better get going on security at the same time. Well, a lot of healthcare organizations have been putting their heads in the sand on this one. in major denial. A lot of them were reeling from Y2K. Some of them spent more money than they had or should have spent, or maybe they had to spend it, but it's left them rather broke, or at least feeling so. A lot of healthcare organizations are struggling economically. Very hard hit by a federal law, the Balanced Budget Act of a few years ago, that in fact took a much bigger bite in terms of Medicare, Medicaid reimbursement than they even intended in Congress. So a lot of organizations struggling financially, which leads to more denial here. Well, I'm not going to start working on this until it's an absolute certainty. And even then, there are organizations saying, well, I'm going to take my chances. How are they going to find me? How are they going to know that I'm not compliant? After all, this is an unfunded mandate, and we talk about the HIPAA police coming out, but the fact is there aren't any. And unless somebody rats on you, you could be non-compliant and actually get away with it. However, it's a bigger risk than some organizations recognize, I think. The civil penalties, if you look at this, it's simply a failure to comply. If there's one regulation or one aspect of this and you're not in compliance, or there's a prohibition and you're still doing whatever it is you're prohibited from doing, there you go, there's a violation. And $100 per person per violation doesn't sound like much. But if they want to make a poster child of your organization, and there are those out there who say they will, because they know people are talking about just getting away with it and trying to put a nice cover on things, but not really take this seriously. And they may well pick an organization that has a real name or deep pockets and hit them for this. And these penalties apply to the transactions as well. So $100 per person per violation could add up rapidly. And you could be talking about millions of dollars in civil penalties, easily. For example, one of the security rule requirements is no shared user IDs. Well, I think you can make exceptions when you buy PeopleSoft and it won't run without a shared user ID. But what about at your application level? A lot of healthcare facilities, I don't know where you work, but in a lot of healthcare facilities, they want to make it easy, especially on those doctors. You know, there's this weird message out there in healthcare. I'm a neurosurgeon, I operate on brains, but don't ask me to remember a 6-character password. At any rate. So they do things like install a radiology system. So this system will let you, say, through a browser, see radiology images and read the text that the radiologist said this patient has such and such on the left lobe, whatever. And to make it nice and easy, there's a user ID of RAD and a password of RAD. Well, and as time passes, every resident who's gone through that hospital knows what the user ID and the password is. They're afraid to change it because they don't want to lock out anybody. I mean, after all, patients may die. That's the #1 red herring you hear in the healthcare industry. So they're living with these systems that are supremely vulnerable, have a lot of very confidential data in them, and they would be in violation of HIPAA if they don't change that. So the HIPAA police come in, they could hypothetically, they say, well, let's look at every employee in the radiology department and every other physician and all the support staff and how many patients do you have, and come up with some calculations, and on that one violation, could talk about big bucks, big bucks. And as soon as they find one problem, just as with Medicare fraud and abuse, they will look for others. Yeah?
The other thing about password abuse is that the doctors not wishing to have to deal with all the grunt work will allow their subordinates to just enter the password and type in the stuff that they would normally have done anyway.
Of course, of course. Actually, some organizations have the wrong policy. They'll say only the physicians can have access. We're not going to let their secretaries have access. Well, that's guaranteed cheating then. They're going to share it. So I would much rather say, let's know who's actually using the system. Let's issue everybody their own ID. No password sharing, please. Well, that's just on the civil side. Criminal penalties. Lawyers say this is an extremely low bar. It's very, very vague. Simply wrongful disclosure. Really, really broad. So that means I work in a hospital. I'm an authorized user. I'm a doctor. But I have a neighbor who's in the hospital. I'm not caring for my neighbor, but I'm nosy. So I look up my neighbor's record. There was a lawsuit in the early 90s. A physician at the Princeton Medical Center in New Jersey contracted AIDS, and all his colleagues started looking up his record. Sued for a privacy breach, and he won that lawsuit. They didn't have any business looking up his record, even though they were authorized users. Well, that would be assuming the organization had made it clear that that was a policy violation, inappropriate behavior, and we will take action. As long as there's that education and policy framework out there, and that's happening, that is a criminal violation. By the way, and the penalties here, depending on the intent and so on, start at $50,000 and a year in prison, go up to $250,000 and 10 years in prison. And the question usually is, who goes to prison? Well, when they come in, if they hear of a violation, these HIPAA police, whoever they're going to be, they will put the organization on the stand first. There have been court cases where they've done this and said, demonstrate to the court that you've got all your security policies in place. Demonstrate that you have formal, documented, written procedures and that you're actually following them. Demonstrate to the court that you've got a formal education program. You're doing security awareness training, formal training as well as periodic reminders. So you're going to have to demonstrate all of that, plus the technical controls. Yeah?
I'm sorry, could you just maybe highlight a little bit about what's being found acceptable as far as either policies or procedures? In other words, what, they say demonstrate that you have one. So I lay a 400-page network security policy at you and say there, right, that no one understands. Or I have procedures and like there's got to be some balance between what gets proceduralized and what doesn't. I'm just curious, how much is enough, or can you give any kind of feeling for any of that?
Unfortunately, that's what everybody's saying. And in fact, when this first came out, the security rule in proposed form, a lot of vendors particularly, but all sorts of people were saying, give us the answers, tell us how long you want passwords to be. Tell us what constitutes a good policy. Give us the language, give us the answers. And they basically said, nope, we're not going to do that and we never will, for a couple reasons. One, they swore to be technology neutral, which I think is appropriate. They also recognized that security risks depend on the circumstances and the organization. This also had to be an extremely scalable rule or regulation. It had to apply to, let's say, a little doctor's office with a couple of physicians and one nurse and one chief cook and bottle washer, the business person or whatever, as well as to hospitals or hospital organizations that cross 10 states with hospitals and physician networks and clinics and home health care and the whole bit. Had to be a rule that was extremely scalable. So the bad news is it comes down to each organization to figure out where your risks are. And I'm preaching to the choir here. Risk is on a continuum, right? And it's a matter of where is there a risk that is just a little too big to accept, and you got to do something about it. It's what security is all about, right? And you better involve your corporate officers and your boards, because ultimately they're the ones who will go to prison. If the organization can demonstrate it's dotted its I's, crossed all its T's, then that individual who snooped or sold data or whatever is going to be liable. But otherwise, it's going to be the corporate officers. That's why, theoretically, they get the big bucks. This isn't any different from other business law. They have responsibilities. So as some organizations involved their boards in Y2K preparation, That's the trend here with HIPAA. Better go talk to the boards and get them involved in understanding, because ultimately it's up to them to accept the risk or not. And usually not means and fund whatever you're going to do about the risk. There's money involved here. Well, if you're directly covered, you need to worry about those HIPAA penalties. If you're not, if you're a business associate, a vendor, whatever, you're probably going to have to agree to some contract language that you might not have seen before. There's a lot of talk now about what it's going to be. Will vendors actually be willing to sign a contract that says, and I promise I'm going to be HIPAA compliant too? What that's going to mean. Very, very subjective, very much up to interpretation. And the covered entities, the hospitals, let's say, and the insurance companies, are not likely to have the resources to really oversee what their business associates are doing. That was the original thought, and everybody said, no way, we got enough trouble managing our own shop, we're not going to go oversee yours too. So there's going to be strong language, and there will probably be indemnification kind of language. If the HIPAA police take us down and it's your fault, you're going to pay one way or the other. So then this final point, if you're unwilling to agree to those terms such as, I promise we will have a robust security program with policies and procedures and education and technical controls and physical controls. If you're unwilling to sign that or unwilling to do it, or on the software vendor side, if you are unable or unwilling to enhance the security controls in the software, you may find yourselves out of business. We'll see. Anybody here actually in healthcare information systems? Nobody here. Okay, the privacy rule. As I mentioned earlier with the fair information practices, what are the rights that the privacy rule gives patients? It follows along that very same vein. Under this privacy rule, individuals will have a right to get a copy of their health record. Now, that's a right in some states already, but not all states. And sometimes the law says you have a right to a hospital record, but not necessarily to a record kept in a private physician's office. So this is broad. And it is probably the strongest plus in terms of rights, privacy rights that come with this rule. So you can get a copy of your own record. If you feel there's an error in it, there should be a process to let you challenge that and get it corrected if it's truly an error. This idea of boundaries, if we want to use your data for something other than treatment and payment and those core operations, we have to get your authorization. And you can withhold it, or you can say, yep, it's okay, and then you can change your mind. You can revoke that authorization. You do have a right, or you will have a right, to know with whom or what organizations your data has been shared, but there are some limits to that. And receiving a notice of privacy practices. We're hearing so much on the web about this. Well, it's now going to apply in the healthcare arena. I think it's a very important piece of this law as well, of this rule, to actually have something in writing that says, by the way, if you come here for healthcare, we reserve the right to use your information for research. And that is standard today. That's very common today. How many of you knew that? You know your data is being used for research all the time when you go to the hospital, whatever. Very, very common, very standard. And in fact, this law does not give you any way to opt out of that. The opt-out is go someplace where they don't do that with your data. The reality is those places don't exist anymore. There's an organization, the Medical Records Institute, headed by Peter Wegman. I don't know if any of you know him. He's long said, we have lost the right to a new health life. Not that long ago, you could move across the country, or not even that far away, and start off with a new physician or a new hospital with a somewhat clean slate. Now, clearly, when a physician examines you, there are certain things you cannot hide, but there are lots of things that you can and that you don't have to reveal. If you were involved in drugs or you had an abortion 30 years ago, you may be able to leave that behind. Now, the physician may be able to see signs on examination, but maybe not. Well, that right is essentially vanished in this country. At any rate, file a complaint of noncompliance. Once this becomes effective, anybody can complain about any entity. And you don't have to go to the local hospital and complain. You can go directly to the Secretary of Health and Human Services if you feel that, in a very basic way, they are violating the security and privacy rules here. I think they're going to be inundated with complaints. Well, what does the privacy rule require of organizations that are covered by it? You must have a security program in place. You have to have security safeguards. You have to have somebody designated as a privacy officer. You have to have policies that describe in pretty much detail exactly when this protected health information may be used or disclosed, and they make a distinction. Use is internal and disclosure is external. When you have to get the individual's authorization, when you don't, when it's required by law, all kinds of ins and outs of that. Now, we do a certain amount of that already, especially in hospitals. There's usually a medical records department or health information management, and those folks make these policy decisions all the time, especially when it's a question of a record going outside the organization. But this really requires a lot more specificity. That point about de-identification. When are we going to de-identify data before we give it away or use it for some purpose? And there is now a requirement that you have to de-identify data if de-identified data will serve the purpose, and you can do it at a reasonable cost. It's not good enough not to de-identify because you don't want to spend the money. If you are not going to de-identify, let's say there's a research or some kind of effort going on, you need individually identifiable data, then you must demonstrate that you have used or released only the least amount of information that's necessary. Basic information security principle, but here it shows up in the privacy rule. Minimum necessary. Auditing and reporting these secondary disclosures. If I'm selling your data for marketing, which hopefully you approved of in advance, I better be auditing that so that if you knock on the door and say, I'd like to know who's gotten a copy of my record, you can actually turn around and produce this report. This is not going to be simple for the healthcare industry to do. Not trivial. The mechanisms are typically not there today in the systems. Yeah?
Does that include like research? That I want to know who researchers have gotten my data?
Research is, in most cases, probably not covered by this, the auditing for disclosure. Research increasingly is considered one of your core operations. If you're a hospital, for example, and you've got an institutional review board in place, you're getting federal money and you're doing research, that's an internal use. It's part of your basic operations and various other, play around with the terminology, but essentially that's a use. It's not a disclosure, and so it's outside.
So what's to prevent the company wants to do a mass mailing to say, oh, well, we're doing research?
Well, mass mailing, two of the issues that came up with the proposed privacy rule were fundraising and marketing. Privacy advocates were saying, those are things where there's the boundary issue, and you need to ask and get permission before you use personally identifiable information for fundraising or for marketing. They waffled in a major way and backpedaled on the final privacy rule. And essentially, most fundraising and marketing that get done today will be considered core operations, and therefore you can't opt out, essentially. And they're often internal use, so it's not even audited. So Workforce training, and originally, here's another one they waffled on, and I don't quite understand why. There's no longer a certification, and a certification in this context is, I went through the training program and I signed something that says, I promise, I understand the policies and I promise to abide by them. They have dropped that as a requirement, even though that's a standard requirement in most hospitals today. And it's expected as part of the accreditation of most healthcare facilities today. So why they dropped it, I don't know who was lobbying against that one. Yeah, you had a question?
Yeah, a question. If I voluntarily participated in a drug study at a hospital, can I have access to those records on those?
Well, there are a couple things that come into play. Let me repeat the question. If you voluntarily participate in some kind of a drug study, say at your local hospital, for one thing, it depends on what kind of drugs. No law is in isolation. There are always other laws that you have to look at in the context. For example, a similar but more stringent state law takes precedence over HIPAA. If you live in Maryland, you have to, and you say, I'd like a copy of my record, I think you only have something like 20 days as a hospital to get a copy of the record available, whereas HIPAA says you've got 30 or 60 days. So state laws may be similar but more stringent. In terms of alcohol and drug abuse, drug from that sense, there are all kinds of state and federal laws, as well as, more stringent protections, privacy protections. If you're participating in a research study that's like a blind study, you obviously can't have access to your record, and you've hopefully been instructed about that and signed off, because if you know whether you're taking the placebo or not, then your participation in that kind of study is moot then.
No, I mean afterwards. It's all done, over, finished.
After the fact? I would assume after the fact, that's part of your medical record and you'd get a copy of that, you could. Yeah, Jack.
It sounds like you could do a denial of service attack by getting a lot of people to ask for their records.
It's like 800 number. 800 number, everybody calls.
I don't know, is my conclusion correct?
Well, one of the things, if you read through the Federal Register where they publish all of this, part of this is, with any federal law, they're supposed to go through the cost-benefit analysis, trying to figure out how much is it going to cost the healthcare industry to implement these rules and regulations. And of course, a lot of it is extremely broad stroke estimate. You know, they're sort of picking numbers out of the sky. And they are also taking numbers from organizations that clearly want to tilt those figures one way or the other for their own interest. But there is some concern that as soon as this goes into effect, or the compliance deadline hits, let's say around 2 years from now, probably all of you will get a mailing from your health insurance. How many of you are part of a health insurance plan? Most of you. You will probably get in the mail this notice of privacy practices from your insurance plan. And if you go to a doctor's office or maybe a dentist or other office, you'll see the same kind of thing sitting out on the counter, whatever. It's going to raise consumer awareness, for sure. And you know the media will have a field day because it makes a good story. And so there is a concern that when that happens, there will be a flood of requests. Oh, you mean I can look at my record? And there'll be a huge number of requests. I think the reality is, it'll be a blip, but it's not going to be overwhelming because people are generally lazy and too busy with other things. Just like I asked, how many of you gotten your credit report? Not that many of you. Yeah.
Just that I was going to say, I would expect that at least some organizations, especially ones that have everything stored most electronically, like a health insurance provider, they could easily give you access over the web, etc. You know, I won't. The technical station, that doesn't really matter. The idea is that I would have to expect that if I'm an organization and I'm expecting at least some number of increased requests, that's the most cost-effective way to do it, and then any other solution would get shot down if someone would say, well, why don't we just put it on the web, right? And then just fill whatever specific security requirements exist for that medium.
Well, I think a lot of organizations, especially if they're new healthcare organizations and they are web-based, or even older ones, will attempt to make that available over the web. But what do you do about the low-tech patients, the people who don't have web access? You're going to have to provide an alternate mechanism in most cases, unless you're purely web-based. Let's say you're an online pharmacy, and you're only, you're not bricks and mortar, you're purely online, internet, then you're going to develop some kind of facility online for sure. However, I'm jumping way ahead here, but in the proposed security rule, one of the requirements that has been overlooked by the vast majority of people who read this requires that if you're using the internet, you got to have two things in place: encryption, okay, and get this, irrefutable authentication. That's the term they use, irrefutable. Now, I think when queried, they said, oh, well, two-factor authentication. Well, why didn't you say that? But how do you deal with two-factor authentication? It's one thing when it's your own workforce, but how do you extend that to all of your patients or all of your members? We're talking about, I know the security architect at Blue Cross Blue Shield of Michigan, and she's hopefully implementing some sort of a PKI situation. But they have to deal with something like 50 million subscribers or members. So there are some very serious challenges there in terms of the authentication piece, I think. But I'll come back to that. Business contracts, sanctions, so on. Security rule requirements. Well, the folks who wrote this, nice bunch of guys at HIPAA, I know a lot of them, and some NIST people and so on. But they weren't, from what I can tell, security people. They were IT people primarily. And so the structure of this, the way it's written, is really kludgy and disorganized in my opinion. But they would say, we just listed this stuff essentially in alphabetical order, a lot of this, put it into a grid, and some of it is very detailed, like no shared user IDs, and some of it's extremely broad, like you must assess your risk. So it's kind of all over the place. I suspect that if we'd had BS 7799 as an ISO standard, when these folks were charged with coming up with a security rule, they would have just said, go read, what is it going to be, ISO I 7799? Just go read that and do it. At any rate, this is what we got. Administrative procedures is their term, but it's essentially policies and procedures and the training program. Certification, this is technical certification of the systems and the whole environment. Totally new concept to every healthcare organization I've ever come across. Boy, do they not know what they're in for. Chain of trust, partner agreements, so it's legal documents. It's these agreements with your business associates or business partners. But do you even know who they are? Some of the Y2K work should help with that, but it's a challenge to even know, especially in a large fragmented organization, who has access, what third parties actually have access to protected health information. Disaster recovery, contingency planning, we ought to have that already. Record processing controls. All right, here's another age question. How many of you are old enough to remember when the department was called data processing? A few of you. Well, that's what this is. It's the data comes in, and do you have a tape management system to say what's coming in when and when it's getting archived or destroyed and what's going where? How many of us have actually done this and really documented this? Whoever documented this stuff? This is what we did. We didn't document it. Well, you got to document it. Of course, the big one here is disposal. Disposal of paper, disposal of electronic. The best disposal, I sort of poll people, best disposal I've come across is cola. Doesn't matter whether it's Coke or Pepsi or the cheap imitation. Any of you using cola? Really etches the stuff right off. And apparently it's very effective and cheaper than a lot of other mechanisms. I've heard of people drilling holes and then somebody else says, you can still recover other parts on that device. So, cola. Access controls. Getting access, keeping track of it at the least necessary level of privilege, reviewing it, making sure that when people change roles, their privileges change, and the termination, when people leave the workforce. How do you ensure that they no longer have access? And that's not trivial, right? It sounds as though it should be, and the public thinks it should be. In the Boston area, there have been some real horror stories because people left, the account was not deleted, somebody else got a hold of it and used it in a very inappropriate way. Headline news, and the public is not sympathetic. Well, you knew the guy left, how come you didn't delete the account?
Because HR doesn't notify that that person's either been terminated, resigned, or retired.
What about when HR doesn't even know? Lots of times HR doesn't even know. Lots of times in healthcare, and by the way, use this term workforce. Lots of healthcare organizations, you think of, say, a teaching hospital, probably a third of the people in the workforce who have access to this information are not employees. They are physicians who are credentialed to treat patients in this facility, but they are not employees. How about all the medical students and pharmacy students and nursing students and social work students and residents and volunteers, the little ladies who sit in the hall and tell you where your mother is? They are all now part of the workforce, and all of your policies have to apply to them. Now, a lot of organizations have focused their education on new employees, and their disciplinary action comes out of the HR department, and the ultimate, of course, is, we're gonna fire you, no more paycheck. What do you say to a volunteer? We're gonna fire you? Whoopee. What do you say to a med student? Well, HIPAA now says, you better sit down, you better form an information security committee. HIPAA doesn't say that, but it's the only way to go. And you better discuss this stuff in advance, and you are required to come up with guidelines for disciplinary action for everybody in your workforce, all types of people in your workforce, not just your employees, something that most healthcare organizations haven't even begun. Auditing. Well, two types of auditing. I'm running out of time. There's the out-of-the-box auditing, unsuccessful logon attempts, somebody changed the security parameter, and by the way, passwords aren't required anymore, the obvious ones. But then there's another level of auditing, and that is something that is a little peculiar to the healthcare industry, I think. For authorized users, once they're logged into the application, which patients did they look up?
Only their own. Should be only their own.
Well, it should be only, quote, their own. But if you can come up with an algorithm that defines their own, you will be a billionaire.
That's easy. Anyone who's a patient of the organization.
Oh, right!
Well, I mean, you know,
That's today's default.
if
That's
you're
the
left-
problem.
but
That's
if
the
you're
problem.
If you're left to define these things yourself, what is an organization going to do? They're going to say, well, we have no way of, you know, because there's all sorts of interdepartmental stuff. You can't do it departmentally. You can't do it by shift. There's just no way to justify it other than to say, our patients.
Well, the fact is, what you've just said has been the traditional answer. Well, we can't do it. So you're on your honor. Here you go. You have access to the entire database. For example, at Mass General, it was 4 million patients, and we had 6,000 users who had access to this clinical system that had 5 million patients. And you sign on the form and you say, I promise I will only look up patients where there's a business need. Well, you know, in the olden days, that sort of trust model would work. Today, that's ridiculous. With 5,000 users, you think every one of those 5,000 users is upstanding and totally honest? How about when they dial in or come in through the internet from home at night when nobody else is watching? The fact is that inappropriate snooping, because of that situation, is rampant. Rampant. It's one of healthcare's dirty little secrets. People are looking up each other. If you're working in a healthcare facility, you're looking up your boss, you're looking up your neighbor, your enemy, your family.
Yeah, but if you're auditing who's doing it, and you publicly fire the top doctor in the hospital because he looked at some wrong patients, people are suddenly going to start getting a little bit more nervous and realize that there is somebody looking at them.
Well, in fact, there are physicians who say that too, but there is a double standard, and I have yet to hear of a physician being actually fired. For one thing, you don't fire them because they're usually not your employees anyway. But there is very much a double standard, and in fact, everywhere where I've worked, nurses have been fired, and billing people and other sorts of people have been fired, and it still happens. There are still people who just don't believe they'll get caught. Yeah?
Can't they move to a system that uses mandatory access control, like down in the financial world, where, for instance, you only have permission to do certain things, or you only have permissions to access certain accounts?
The problem is, certainly to do certain things, we know how to do that. We've known that for ages. I'm a registration person. I only get access to demographics and the insurance and guarantor fields, and I don't get access to clinical data or whatever. We know how to do that. The problem is that other access, which subset of patients or plan members am I allowed to see? And there are some algorithms you can develop based around physicians. More and more systems will let you designate who's the PCP, the primary care physician. That's the gatekeeper. And who's the referring physician, who's a consulting physician or an attending or whatever. Well, that's fine with doctors. Well, okay, let's assume that you can pre-identify all the support staff, the secretaries and the nurses associated with each physician or each physician team. So you've extended a little farther. But there are, especially in a teaching and research hospital, it just gets out of control. And there are no way, I don't know any organization or any vendor that's come up with a great algorithm. They're trying something in the UK. Any of you know Ross Anderson at Cambridge? He's worked with the health system in the UK and implemented basically an ACL for each patient. They have it's the GP, they're sort of a PCP model. And that person, that physician basically controls access to his or her patients. And each patient has their own access control list. They've got a different model though, and supposedly it's working in these two hospitals. But I don't think, and I think this is a challenge to the industry to come up with really clever stuff. I don't think it fits the model very well here.
You're looking for snooping, right?
Yeah?
I mean, wouldn't it be easy just to take averages of how many lookups is a person doing and just
Yes. Some vendors are putting this audit trail into their systems at the application level, so you're tracking every lookup. It's not just an update and not just a change. And then trying to develop patterns and look for the anomalies. But you've got to do it per institution. It's really very much in its infancy. It's not well developed, but I think there's a great opportunity for vendors there. Another vendor is working, or Cerner came up with ways of defining relationships. It only goes so far though. So we've got problems here with that snooping issue. Personnel security, you all know, you can put this great security program in place, all the policies and the technical controls, but it's ultimately up to the individual. And now that we've got intelligent desktops and we don't have dumb terminals anymore, you need protections at the workstation level. So it's teaching people, what are you allowed to run on your workstation, what are you not, what about virus protection, all that other stuff. Logging off when you leave the workstation. Even turning the screen. They make a big deal about how the screen is turned, especially in public areas. If you think about going into a doctor's office or a hospital facility, think about whether you can actually look over the shoulder and read the screen or overhear phone conversations. It's very common. So there's a real strong non-technical component to all of this. Configuration management, security incidents. Again, totally unheard of in the healthcare industry. What's a security incident? Security management, that really covers all the bases. Termination, again, how do we make sure that access is terminated when someone leaves? Training and security awareness. Physical safeguards. Some of this, they put in physical, you kind of wonder about like security awareness training as a physical safeguard. Oh well. Media controls, pretty obvious. What's coming in, what's going out. Workstation use policy, as I mentioned, location, positioning. One of them I get a kick out of, they said, workstations that are used to access extremely secure information should be kept in locked rooms when possible. Imagine an intensive care unit in a hospital or an inpatient area. Everybody uses this device, and it's really sensitive. We're going to lock it in a room? I don't know where they got that one. They were kind of out in left field. Technical controls, access controls, audit, authorization, data integrity, entity authentication, event reporting, alarms. A lot of this is stuff that if you've been here all today and tomorrow, you know about all that stuff. Well, what does this mean for vendors? As I mentioned earlier, these business associate contracts, expect to see language, expect to have discussions, lawyer-to-lawyer discussions about the contract language here and the expectations. Also, it is likely that those contracts are going to claim that the covered entity, the healthcare organization, reserves the right to unilaterally break the contract if there's been a security breach. The business associate will be required to report if there are any breaches or improper disclosures, report that back to the covered entity, the hospital or the insurance plan or whatever. Audit when the information is redisclosed under certain circumstances, and of course the Secretary of Health and Human Services has carte blanche. She or he can go anywhere and do anything. Explicitly, I mentioned earlier, unique user IDs. Obviously, if you have an audit trail, you need that. But clearly, too, if you're sharing user ID and password, you don't have great security. You don't know who's getting in. Authentication. They say you can use any of these, a password or a PIN or a token or a smart card or biometric or even callback, please. I wouldn't want to use callback by itself anyway. And if it's over an open network, irrefutable. Well, there's some confusion about what an open network is. They contradict themselves in the security rule. It is clear, crystal clear, that this is at a minimum over the internet. Whether it's over lease lines, dial-up lines, a little unclear. My guess is they won't make it an absolute requirement except for the internet with the first pass. Authorization has to be role or user-based. Obviously, if the software provides ways to modify that by location or by date and time, and the most common location, use of location is in an inpatient facility where you have nurses and aides and whatever working on 3B, and they can only access the records of patients who are physically on that unit. It's a very common feature. Date and time don't work real well in a healthcare provider setting like a hospital, because people are always doing shifts and they're working 7 by 24, 24 by 7, but if you can, you obviously should take advantage of them. Here's one that I find there are a lot of crummy systems out there. And if you're expected to be able to review periodically who has access to this application and make sure that in fact the person's still here, still needs the access, well, what if the system can't report that information back to you? They might be able to give you a list of users or accounts, but the system's got to be able to reflect back what privileges are associated with that user as well. Some applications can't do that. An auto log off or inactivity timeout. And this is a lot more challenging than I think a lot of people realize. Also, they literally say causing the session to terminate, not suspend. And that causes problems in a lot of organizations. When the log on process, especially with client server, can take 60 or 120 seconds, people are very reluctant to log off because the person walking up right behind them. Think again about a nursing station in a hospital. There's huge resistance to that kind of having to log off when you walk away. So, for example, there's some interest in proximity badges that at least have the appearance of logging you on faster. I would argue that it's not necessarily true, but they also clearly will log you off as soon as you walk away. So that's the advantage there. Every implementation of inactivity, timeout, or auto log off I've ever seen has been different. And a lot of them are very crude, and the vendor clearly took the cheap way out in terms of software, which is my background, software development, so I can tell. But this is an area where some flexibility is going to be very valuable. Data integrity, and they suggest things like checksums, double keying, message authentication code, digital signature, message hash. Obviously, a lot of this is built into protocols today and into our applications. So in some ways, I think this is less an issue for us than some of the other areas. In transit, integrity controls, message authentication, they split out data at rest and data in transit for some reason. Access controls, or say over the internet, you've got to have encryption. So over an open network, such as the internet, again, alarms and audit trails, entity authentication. Hopefully you're doing that all locally anyway, and event reporting. The additional one, though, is encryption. Now, HIPAA, the Healthcare Financing Administration, is a part of HHS. And HIPAA actually has an internet security policy. They do specify, if you're interacting with HIPAA, to use these encryption algorithms and minimum key lengths. So everybody is glomming onto these and saying, well, if we can live up to the HIPAA policy, we will surely be HIPAA compliant. And everybody loves to be able to say, here's the list. Are you using these algorithms and none other? Stay away from the snake oil, obviously. Secure remote access. Again, this group was, I don't think, very technical and not very secure in terms of their professional background. They get real vague here. You simply have to protect the remote access points and external electronic communications. They don't really tell you how or to what extent. Again, you have to figure out, or these covered organizations have to figure out their own level of risk and what tools and techniques they need to bring to bear. Very much on our own on this. The event auditing, I've already touched on this. System certification, and so on. Disaster recovery, virus protection, de-identification, optional or implicit, but it's certainly, that's not trivial, and you need a real statistician to know when you've appropriately de-identified. Limiting access by reason. When the privacy rule says you have to get authorization to sell this data, you're going to have to be able to track that preference on the part of the individual. And then when you want to use the data for that purpose, you're going to have to refer to this authorization. Did the patient authorize, yes or no? And that isn't rocket science, but it's nowhere in healthcare today. Amending records, some systems allow that, others don't. Well, some people will go through in the healthcare industry, or some consultants to them, and say, these are the things that HIPAA says you have to have in place. And by the way, it doesn't say anything about how long your password should be, or password aging, or makeup, any of that. The deal is, even if they don't tell you, the intent is that you are going to know that. You're going to know that you have to think about what's an appropriate password length. And if you decide that 2 is long enough and you get audited, you're going to be in big trouble. So there's this expectation that's very implicit. A lot of things are implicit in there. Well, someone earlier was talking about the common criteria and an effort to take some standards and to be able to certify products to help the healthcare industry buy things off the shelf that have the label on them, the UL label. So there is this group headed by Lou Lorton, the Forum on Privacy and Security in Healthcare, and really working to push this concept, which I do think has a lot of merit. Here's some other resources. This report, For the Record, is an interesting one because basically the security rule is lifted from this report. In the mid-90s or so, the National Research Council set up a subcommittee to study the state of security in the healthcare world, electronic security specifically. And the report, I actually met with the committee a couple times, and it was mostly healthcare people and a few other technical people and so on. The first draft of the report I heard was really very damning, very negative, and they were encouraged to soften it up. But basically they said, you know, the king's not wearing any clothes. So a lot of that actually formed the basis for the security rule. ENAC, Affect, and WEDI have been around for a while. They tend to be focused on, well, the second to, at any rate, those transactions, but they're getting into the security side of things as well. WEDI especially, the work group for EDI, has started a whole HIPAA implementation effort, implementation support effort, voluntary. JITA, the Joint Healthcare IT Alliance, AHIMA is the medical records professional group. The Health Privacy Project, this is headed up by Jan Lori Goldman, probably the most well-known health privacy lawyer in the country. This is out of Georgetown, I believe, and she's advised the government regularly on healthcare security issues. In fact, I think when Clinton announced the final privacy rule, Jan Lori was there at his side. You want to track the bills? Thomas, as in Thomas Jefferson, libraryofcongress.gov. What's happening now? Well, a lot of healthcare organizations are just now getting educated. What is HIPAA all about? What are the security and privacy requirements? And what the heck is security? Working on getting senior management support, buy-in, funding, one of those perennial problems. Trying to figure out where to fit security into the organization. And that is to me, that is extremely critical that they get it right, that they understand information security, what it's all about, the fact that you don't just pluck somebody from the organization and say, okay, you're our stucky. Somebody from medical records. A lot of organizations have already said, you are our security officer, you are our privacy officer, and they are totally inappropriate. They've totally missed the boat. These people know zip about security. So I walk around with my CISSP pin and my brochures teaching people about ISC squared and so on. So a lot of figuring out where does this fit in the organization, stressing that this is not like Y2K, this is not a project. Security is a whole new function in your organization, folks, permanent. Get over it, it's not a project. Yeah, a lot of the people heading up HIPAA are Y2K project managers. Wrong, 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 in most cases. Baseline risk assessment. HIPAA says you got to do one, and of course that's the logical thing to do anyway as a starting point. Where are we falling short in terms of security? What are we going to do over the next 2 years in terms of, yes, projects at that point? How do we fund them? Who does them? And so on. Yes?
Can you get HIPAA to sign off on a security policy before you implement it? Say, for example, you go through the risk assessment, you go through a development policy, before you actually go into production. Can you have their okay?
Who's they?
If they're going to come in and audit you don't have.
Well, they're not going to come in and audit exactly. I mean, there's not going to be, as there is an accreditation, the Joint Commission on Accreditation of Healthcare Organizations and the National Committee on Quality Assurance, NCQA, they come in and they accredit the organization. Do you have nice care of the patients, and are you documenting the treatment, and do you have confidentiality of the records, and so on? And those organizations have sworn to beef up their accreditation of health plans and provider organizations. But this is so vague and subjective. There are not going to be people from the federal government who accredit or HIPAA certify healthcare organizations. You can pay millions of dollars. Well, I don't know, PricewaterhouseCoopers. Is anybody here from PwC? They're probably offering HIPAA certification or some security certification that they would probably claim would make you HIPAA compliant. You probably have to pay, a couple million. IBM, KPMG, E&Y, they're all jumping on the bandwagon, but there's not going to be somebody from the federal government, or at least it's not expected at this point, that the federal government is going to actually accredit you. They will come in if somebody rats on you, or they're doing a Medicare fraud and abuse audit and they find problems, and they begin to look further and further, and then they'll slap you with fines if you won't comply. Yeah, Jack?
I was going to say the HIPAA police will be your lawyer. I'm just kidding, someone else's lawyer.
Someone else's lawyer. The HIPAA police are all around us. It can be a disgruntled employee, a disgruntled patient, you know, a competitor. Of course, they're going to be worried because they'll get it right back. But an individual, you can get caught in lots of ways. And even if,
security consultant.
pardon me?
It's going to be your security, actually security sales and from the consultant.
Will be the HIPAA police.
Right. Did you know you're not HIPAA compliant? You know, I know about this now, and I really feel compelled to report you if you don't do something about it. Did you know we offer these services?
I wouldn't want to touch that one.
That's RICO.
Yeah, that doesn't quite sound kosher there. But also, I think vendors, for those of you who are consultants or vendors, you've got to be sure if you start playing the HIPAA card that you really do know what you're talking about. You know how to spell HIPAA. You understand what the requirements are. You understand how fuzzy they are. And you understand that, as HHS says, a huge chunk of this is policy and procedure and education. And those of you who are into selling high-tech solutions, your time will come. But most organizations in healthcare have to do the basics first. They don't even have policies that will hold water. They have no or very few written procedures that are truly formal and documented. If you do a word count on this thing, formal and documented come up over and over and over again. Because the NRC subcommittee found that, indeed, we're doing security by the seat of our pants. We're all doing security. We're issuing passwords, and sometimes we delete accounts and whatever. But we're doing it in a very fragmented way. Very fragmented. We don't have this, we don't have specific assignment people, a lot of sysadministrators here, right? You're doing security, who was, oh, you left at the table at lunch saying, oh yeah, and in addition to everything else we're doing, we're deleting users and we're checking the logs and we're doing this and we're doing that, yeah, right. And how many hours in the day are there? And by the way, how about getting educated in security? So we have a long way to go in terms of resources and formalizing the program and how it's all coordinated. Okay, 3 minutes over. Any more questions? Be glad to take them offline. Thank you all very much.